Systemic and segmental MSK Biomechanics, from vector analysis to clinical decision-making in joint and spinal pathologies.
The material covered follows a strictly sequential six-part progression. We begin with premise and muscle mechanics, followed by systemic adaptation and modeling, clinical reasoning and intervention, the integration of neuroscience with clinical response, the scientific positioning of this framework, and finally, the course credentials and details. Part 1. Premise and muscle mechanics, the foundation of structural shortening. In the absence of congenital or acquired pathologies, mechanical joint conflicts and spinal deviations originate from one consistent mechanical process. That process is the structural shortening of the connective component of muscle tissue under sustained compressive forces.
We define structural shortening as the permanent deformation of the muscle's connective matrix. Three distinct systems, psychosomatic, neurophysiological, and biomechanical, converge to cause a sustained increase in baseline muscle tone. Over time, this involves the connective component and produces residual shortening. A shortened muscle inevitably pulls on its bony insertions. When this happens across joints and spinal segments, it alters articular axes, modifies load distribution, and generates the mechanical conflicts that ultimately produce symptoms. Muscle tissue consists of contractile elements that can recover their length and connective components that cannot. In a structurally shortened muscle, the force it produces divides into two inverse proportions: resistant force, or RF, and working force, or WF. Resistant force is the portion absorbed internally just to overcome the rigidity of the shortened connective tissue. Working force is the portion that actually remains available to produce useful movement. As connective shortening increases, the internal resistant force rises and the available working force decreases. The clinical consequence of this altered ratio is critical in both statics and dynamics. In statics, the shortened muscle exerts persistent traction at rest, progressively deforming joint axes before the patient even moves. In dynamics, that increased resistant force interferes with movement, forcing compensatory motor strategies. Because of this dynamic, strengthening a vectorially imbalanced system is often counterproductive. If you strengthen shortened, dominant muscles, you are simply adding force in the exact direction producing the misalignment. The strict mechanical sequence must always be to first rebalance the vectors, and then strengthen. Part 2. Systemic adaptation and modeling, complex systems, and the AIFIM framework. Muscles do not shorten in isolation. When one muscle shortens, the forces acting on its joint change, and the entire complex system must adapt to maintain equilibrium. The body redistributes loads simply to keep the center of gravity within the base of support. This adaptation comes at a cost, which is the loss of physiological joint alignment in other segments, often far removed from the original shortening. This creates a self-reinforcing cycle. Shortening alters axes, altered axes require compensatory activation, and sustained compensation produces further shortening. This is precisely why local treatment alone often produces only temporary results. The specific segment might improve, but the systemic forces generating the alteration remain fully active. This brings us to the AIFMM framework, which operates on two specific levels. First is the interpretive level. Grounded in biomechanics and physical laws, it reads joint alterations as the direct result of muscular forces and anatomical dominances. Vector analysis is the core tool utilized here. It breaks down muscular forces to identify dominant vectors, allowing a practitioner to predict the direction in which an articulation will deviate before even observing it clinically. Second is the applicative level. This translates the interpretive model into direct therapeutic choices. Derived from the Mezier's method, it currently utilizes isometric contractions performed at maximum physiological elongation. This specific technique acts directly on the shortened connective tissue to reduce internal resistant force and restore available working force. It operates strictly within a sequential systemic strategy rather than relying on fixed protocols. Part 3. Clinical reasoning and intervention, diagnostic constants, and therapeutic efficacy. A symptom can be a local condition, a referred problem, or a systemic adaptation. It is required to look beyond the single segment to distinguish these possibilities. When a symptom arises specifically from mechanical conflict, 4 constants are consistently verifiable in the clinic. First, intra-articular mechanical conflict, where forces concentrate in restricted areas. Second, asymmetric vectorial shortening, meaning joint misalignment is always the direct consequence of muscular dominances. Third, systemic misalignment, where the entire articular system, not just the symptomatic joint, deviates from physiological references. And fourth, the systemic distribution of shortenings throughout the entire myofascial system. The most critical clinical distinction to be made is between primary and secondary muscular shortenings. Primary shortenings are generated by the psychosomatic, neurophysiological, or biomechanical systems. For these, vector rebalancing is resolutive. Secondary shortenings, however, are an adaptive response to an alteration originating in another system entirely, such as the visceral, vestibular, or stomatognathic systems. In this case, the muscles are merely the pathway. Without interdisciplinary collaboration to resolve the primary cause, muscular rebalancing will not hold. The diagnostic process utilizes two equations of pathology. Behind labels like low back pain or epicondylitis lies one of two processes. Equation 1 states that there is no external alteration, leading to primary shortenings, an altered sequence, and pathology. The resolution here is vectorial rebalancing. Equation 2 states that there is an external alteration, leading to secondary shortenings, an altered sequence, and pathology. The resolution requires treating the primary cause first, followed by rebalancing. Identifying which equation is active determines the outcome. Intervention operates simultaneously on two tracks. Segmental work targets the specific shortened muscles responsible for the conflict. Systemic control monitors the redistribution of tension, ensuring the local correction isn't simply absorbed by other segments. At the end of every single session, three criteria must be present simultaneously: local improvement, an overall reduction of tension, and greater system adaptability without new compensations. If even one is missing, the result will likely be transitory, and the therapeutic hypothesis must be revised. Part 4. Neuroscience and Clinical Response. Integrating biomechanics with pain science. This biomechanical model does not replace neurophysiological approaches to pain. Instead, it addresses a specific complementary dimension. Central sensitization and psychosocial factors are recognized contributors to chronic pain. However, a persistently compressed disc or a joint held in a non-physiological axis by shortened dominant vectors are also measurable realities. This model works on that peripheral mechanical substrate. By reducing compressive forces and restoring vectorial balance, the actual mechanical input that the nervous system is processing is changed. These frameworks operate on different levels of the exact same problem. Regarding clinical response, measurable changes in joint alignment and symptom reduction typically appear within 2 to 10 weekly sessions for primary dysfunctions. If there's no measurable variation beyond 10 sessions, the primary cause likely lies in another system. Over 40 years of observation indicate that 10 to 15% of patients show limited response, reflecting biological variability and secondary shortenings. Part 5. Scientific positioning, rigorous hypotheses, and clinical evolution. This biomechanical model is not presented as the absolute truth about the human body. It is the most rigorous, testable hypothesis built over 40 years of clinical and theoretical work, translating the early insights of François Mézières into verifiable physical and mathematical language. As the course materials state, scientific rigor means building testable hypotheses, refining them, and accepting they will be surpassed. The existence of different approaches signifies that we are still actively exploring a complex system with limited tools. Part 6. Course credentials and details. Logistics, instructors, and materials. The program is fully accredited, awarding 38 CPD hours through the CPD Certification Service in the UK, and 45 contact hours, or 4.5 CEUs, approved by the Florida Board of Physical Therapy Practice. It is designed specifically for physiotherapists, osteopaths, and rehabilitation professionals. The course is instructed by Mauro Lastrico and Laura Mani. They trained directly with François Mézières in Paris from 1988 to 1990. They founded the Postgraduate Institute AIFMM in 1996, training over 6,000 physiotherapists, and bring over 40 years of clinical experience in musculoskeletal rehabilitation to this comprehensive model. The course includes 18 video modules spanning 32 hours, featuring demonstrations with detailed biomechanical analysis on real patients. It provides complete PDF materials, including over 25 downloadable resources, 12 months of 24/7 on-demand access, and a dedicated chat with the instructors for clinical questions. The video demonstrations include precise anatomical landmarks and verification criteria, providing the objective tools to directly test this physical framework against the clinical realities of daily practice.